Welcome to the Deep Dive, your shortcut to being well-informed. Today, we're taking a crucial plunge into a topic that truly touches countless lives and is absolutely fundamental for anyone aspiring to healthcare, especially those of you navigating the nursing field: neurocognitive disorders. Our deep dive is, well, it's custom-tailored for you, drawing vital insights directly from Varkarolis's Foundations of Psychiatric Mental Health Nursing. A Clinical Approach, 8th edition, by Margaret Jordan Halter. Our mission is to transform dense textbook knowledge into practical wisdom. We're going to unpack complex concepts like mental health assessment, major psychiatric disorders, psychopharmacology, and evidence-based interventions, basically in a clear, accessible way. Think of this as your essential clinical briefing, emphasizing real-world application and those crucial NCLEX priorities. That's the National Council Licensure Examination, your big nursing exam.
Precisely. We want to clarify not just what these conditions are, but why they matter so profoundly in patient care. Our focus will be on helping you distinguish between different disorders and, crucially, understand the critical nursing skills required to manage them effectively. We'll try to bring the material to life with, real-world scenarios so you can actually see these concepts in action.
Okay, so let's set the stage. A neurocognitive disorder.
Right.
It's a broad term for conditions stemming from changes in the brain that profoundly affect a person's orientation, memory, intellect, judgment, and even mood. Our source outlines 3 main classifications: delirium, mild neurocognitive disorders, and major neurocognitive disorders, which you'll probably more commonly hear referred to as dementia. Let's start with the one that often requires immediate, urgent attention: delirium. So, delirium. This is an acute, often reversible cognitive disturbance, and it's surprisingly common, especially in hospitalized older adults. What makes it so critical? Well, our source stresses it's a medical emergency. Left untreated, it carries significant risks: irreversible brain damage, increased complications, even mortality. It's a really rapidly shifting landscape.
It truly is, and the epidemiology here is striking. You could see delirium in, up to 22% of general medical patients, 35% in surgical patients, and it can skyrocket to 80% in the ICU. And for patients over 65, it affects about half of all hospitalized cases. The causes are always physiological and typically multifactorial. We're talking about an interplay of underlying risks like, existing cognitive impairment, older age, severity of illness, infection, polypharmacy.
That's multiple medications at once.
All right. Exactly. Polypharmacy, fractures, recent surgery, or even just a change in hospital room. And many of these factors are, importantly, modifiable. What's fascinating here, and really important for nurses, is that you are uniquely positioned for early detection. The challenge, though, is that delirium is often under-recognized.
Why is that?
Well, because of its fluctuating nature, sometimes communication barriers, or simply being mistaken for something else, like dementia. So your role in spotting this acute confusion is absolutely vital.
Okay, so that brings us to the clinical picture. What does it look like at the bedside?
Well, the cardinal symptoms are an inability to direct, focus, sustain, or shift attention. A key hallmark is its abrupt onset with fluctuating severity.
Meaning they can seem fine one minute and really confused the next.
Exactly. Lucid one moment, profoundly disoriented the next. You'll also see disorganized thinking and poor executive functioning. That's difficulty with planning and problem solving.
Okay. But what?
Other common characteristics include disorientation, usually to time and place, but interestingly, rarely to the person themselves. Anxiety, agitation, poor memory, even delusional thinking are common.
You mentioned hallucinations.
Yes, and here's a crucial differentiator. If hallucinations occur, they are typically visual, not auditory, like you might see in, say, schizophrenia. The DSM-5 criteria really hone in on this. You're looking for that disturbance in attention and awareness, and acute onset with rapid fluctuations and other cognitive disturbances, all directly due to a physiological cause.
Right, a direct physiological consequence.
This is where your nursing assessment becomes absolutely paramount. You're observing for that abrupt reduction in clarity of awareness and impaired attention. You might find yourself, repeating questions because their attention just wanders. And here's a common pattern you mentioned. Disorientation is often worse at night. That phenomenon we call sundowning.
Sundowning, right.
For cognitive and perceptual disturbances, recent memory deficits are very common. It's also vital to differentiate between illusions and hallucinations.
Okay, what's the difference there?
Think of illusions as misinterpretations of a real stimulus, like seeing the folds in a blanket and thinking they're rats. You can usually clarify these. See, it's just the blanket.
Got it.
Hallucinations, on the other hand, are false sensory stimuli, like seeing giant spiders crawling on the bed when there's nothing there. In delirium, these are, as we said, usually visual.
Okay. And physically, what should nurses look out for?
From a physical standpoint, a person with delirium might wander, they might try to pull out IVs or catheters, and they're at a high risk for falls. You'll observe self-care deficits, potential skin breakdown, infection risk, and look for autonomic signs like a rapid heart rate, sweating, dilated pupils, elevated blood pressure. These require immediate attention. Their sleep-wake cycle often reverses, and they might be hypervigilant, kind of constantly scanning their surroundings, and always, always suspect medications, especially polypharmacy, as a potential trigger.
And their moods and behaviors. You mentioned agitation.
Yeah, they can swing dramatically from fear, anger, or anxiety to euphoria or even apathy. We sometimes see patients who are hyperactive and agitated, or conversely, quietly delirious, appearing calm, but actually deeply confused.
The book mentions a case, Peter Wright.
Yes, Peter Wright, 43 years old. After open heart surgery, he became acutely delirious. He was convinced nurses were trying to steal his organs, was yelling, trying to climb out of bed. It was terrifying for him. And even after the confusion cleared, that terror he experienced, it stayed with him for months. This really shows you the profound internal experience and, of course, the safety risks involved.
Absolutely. So given all that, what's the priority nursing diagnosis?
Your top nursing diagnosis will almost always be a risk for injury. Why? Because of those distorted perceptions, the wandering, the potential to pull out lines, the high fall risk.
Makes sense.
Other common diagnoses include acute confusion, risk for deficient fluid volume and disturbed sleep pattern, impaired verbal communication, fear.
Okay. And the goals, what are we aiming for?
For outcomes, we aim for the patient to return to their baseline level of functioning, their premorbid level. We want them to remain safe and be oriented during periods of clarity, using aids if needed. Planning prioritizes safety above all else. Ask yourself, are there visual or auditory aids available? Can family members be present? Is the environment providing consistent cues? Continuity of care providers? These things matter.
So what do we actually do? The interventions.
Okay, the core intervention is twofold. Keep the patient safe and identify and correct the underlying cause immediately to prevent irreversible damage.
Right.
This means minimizing physical restraints. Family presence can often help avoid these and providing supportive measures. Practically, continuously monitor their neurological status, but, and this is important, avoid quizzing them on orientation. It can be really frustrating for them.
Good.
Administer PRN meds cautiously. Assist with basic needs, nutrition, elimination, hygiene. Acknowledge their fears. Provide realistic reassurance. If they're agitated, maybe limit decision-making for a bit. And crucially, accept their perceptions. Don't argue with their reality, no, there are no spiders. Instead, respond to the underlying theme or feeling.
How'd that sound?
So if they say, there are rats on the bed, you might respond, I don't see any rats right now, but I can see you're very frightened. Let me smooth out your blanket and stay with you for a minute. See the difference?
Yeah, acknowledging the feeling behind it.
Exactly. Always approach slowly from the front. Introduce yourself clearly. Use simple, direct communication. Encourage family presence whenever possible. Maintain a well-lit, hazard-free environment. And make sure they have an identification bracelet. Consistency in routine and caregivers helps immensely. Use environmental cues like clocks and calendars. If they seem overstimulated, try reducing the noise and light. And always encourage the use of their sensory aids, eyeglasses, hearing aids.
And the number one rule.
The golden rule here. Never leave a patient in acute delirium alone. #, 2, mild and major neurocognitive disorders, dementia, and Alzheimer's disease.
Okay, let's shift gears now. We're moving from the acute picture of delirium to the other side of the neurocognitive spectrum. Mild and major neurocognitive disorders, which most people know as dementia. Unlike delirium, which is acute and often reversible, dementia is typically a progressive deterioration of cognitive functioning and global intellectual impairment. It's important to remember it's not a specific disease itself, but rather a syndrome, a collection of symptoms.
That's right. And the DSM-5 categorizes these as mild or major neurocognitive disorders based really on how much they interfere with a person's independence in everyday activities.
And the most common form of major NCD is Alzheimer's disease.
By far. Alzheimer's accounts for a staggering 60% to 80% of all dementias. It affects people across all demographics, men, women, various ethnicities, rich, poor. Most are 65 or older, but early onset Alzheimer's does exist.
What are the risk factors we should know about?
Well, there are biological factors. Genetics play a role, specific rare mutations for early onset, and a susceptibility gene called APOE for late onset. But neurobiological factors are critical. We see neuronal degeneration starting in the hippocampus, the memory center, then spreading to the cerebral cortex. This seems to be driven by two key things: beta amyloid plaques accumulating outside neurons, disrupting communication, and tau tangles accumulating inside neurons, basically blocking nutrient flow.
So plaques outside, tangles inside.
Exactly. Cardiovascular health also significantly impacts risk. Things like inactivity, high cholesterol, diabetes, obesity, and repeated head injuries or TBI can also increase risk. Environmental factors like social engagement and diet. The evidence is still a bit limited there, but potentially modifiable.
This brings up a really critical point for you as future nurses. Distinguishing normal age-related forgetfulness from Alzheimer's memory loss. How do we tell the difference?
That's crucial. For typical aging, you might occasionally forget a name, but remember it later, right? Or make minor errors balancing a checkbook. It happens. With Alzheimer's, however, the memory loss disrupts daily life. We're talking about forgetting recently read material, significant challenges with planning or problem solving, or maybe forgetting how to complete familiar tasks, like using the microwave or paying bills.
These aren't just senior moments, then.
Definitely not. They're profound changes impacting independence. The Varkarola's text has a great table, Table 23.2, that highlights these differences really clearly.
Okay. And how does Alzheimer's typically progress?
Well, the clinical picture and progression are insidious, meaning they develop slowly and subtly. Early on, individuals might experience a loss of energy or drive, but their personality and social behavior often remain intact. This can lead others to kind of minimize the changes, brush them off. Depression can also occur early on. As it progresses, we generally see three main stages. Stage 1, or mild Alzheimer's, involves memory lapses noticed by the person and maybe loved ones, difficulty finding words, misplacing valuable objects, trouble with planning. They can still function pretty independently, though.
Okay, stage 1,
Then comes stage 2, moderate Alzheimer's. Here, symptoms become much more noticeable. The person confuses words, gets frustrated or angry more easily, forgets personal history, becomes moody or withdrawn. They'll likely need help choosing clothes, may start having bowel or bladder issues, and their sleep patterns can change: restlessness, wandering at night. Suspicion, delusions, maybe compulsive behaviors might emerge here too, like hand-wringing.
That sounds significantly more challenging.
It is. And finally, stage 3, severe Alzheimer's. This is where the person loses the ability to respond meaningfully to their environment, carry on conversations, and eventually control movement. They might say words or phrases, but communicating pain becomes very difficult. They'll require extensive, really around-the-clock assistance with daily activities, lose awareness of their surroundings, have changes in physical abilities like walking or swallowing, and become very vulnerable to infections like pneumonia.
That's a tough progression. And the book details some specific behavioral manifestations nurses need to recognize.
Yes, several key ones. There's confabulation, that's the unconscious creation of stories to fill memory gaps. It's not lying, it's more like the brain trying to make sense of things.
Like the example of discussing politics with the president.
Exactly. Then there's perseveration, which is the persistent repetition of a word, phrase, or gesture over and over. Aphasia is the loss of language ability, starts with difficulty finding words, can progress to babbling or even mutism.
Okay.
Apraxia is the loss of purposeful movement. So they can't perform familiar tasks like maybe putting their arms into trousers when trying to get dressed. Agnosia is the loss of sensory ability to recognize objects.
So they might not recognize a ringing phone sound or a toothbrush.
Correct. Auditory agnosia, visual agnosia, tactile agnosia. Then there's hyperorality, the tendency to taste, chew, or put everything in their mouth. And hypermetamorphosis, which is the urge to touch everything in sight.
And sundowning again.
And sundowning, yes, that increased mood deterioration and agitation, often worsening in the late afternoon or evening. Same term as in delirium, but here it's part of the dementia progression.
The book uses the case of Mrs. White to illustrate this.
Ah, yes. Mrs. White, the retired teacher. Initially, she joked about senior moments, but her daughter noticed alarming changes. Mrs. White, who loved cooking, became frantic, trying to make lasagna, struggling with basic steps. That's apraxia. A crisis hit when she stopped taking her daily thyroid medication. Her house became messy, her clothes didn't match, eating became difficult, she couldn't recognize food, didn't know what a spoon was for. That's agnosia. She started wandering at night, emptying cupboards.
And the fire incident.
Tragically, yes. She set paper towels on fire on the stove. This really highlights the apraxia, the agnosia, the sundowning, and the profound safety risks that often lead families to that incredibly difficult decision of placement in a care facility.
Such a hard situation for everyone involved. So how does the nursing process apply specifically to Alzheimer's? Assessment.
Assessment is critical. Remember, the onset is subtle and family denial is common, so their observations are invaluable. Diagnostic tests primarily rule out other conditions.
Like delirium or depression.
Exactly. It's crucial to differentiate. Remember, delirium. Sudden onset fluctuates, often reversible. Dementia like Alzheimer's. Slow onset, progressive, generally irreversible. Depression can mimic cognitive issues, but often linked to crisis, reversible with treatment. Table 23.4 in Varkarolis lays this out well. Brain imaging like CT or PE scans can show atrophy. Mental status questionnaires like the Mini Mental State Exam MMSE are standard tools. You need a complete medical and psychiatric history, medication review, nutritional evaluation, and rely heavily on family input.
What about cultural factors?
That's a really important consideration. Cultural beliefs can create barriers that delay diagnosis for minority groups. Things like believing memory loss is just normal aging, lack of knowledge about dementia, language barriers, sometimes shame or stigma.
So nurses need to provide culturally sensitive education.
Absolutely, it's a key role. And for your own well-being as a nurse, caring for people with cognitive impairment is stressful. It's vital to have realistic expectations. Set attainable outcomes, maybe just patient feeds self with a spoon today, that's a victory, and proactively cope with the stress by understanding the disease.
Okay, so nursing diagnoses. Still risk for injury?
Yes, risk for injury remains a top priority: wandering, falls, burns, medication errors. But other diagnoses are also very common: impaired verbal communication, impaired environmental interpretation syndrome, impaired memory, confusion, and importantly, caregiver role strain that's almost always present, and anticipatory grieving for the family and sometimes the patient.
And outcomes and planning. Similar focus.
Outcomes focus on patient safety, maximizing self-care ability, effective communication, and providing that vital family support. These outcomes must be measurable and, crucially, evaluated frequently because the condition deteriorates. Planning centers on the person's immediate needs, their current level of functioning, and robust caregiver support.
So interventions. What's most effective for Alzheimer's care?
Our source highlights the person-centered care approach as the single most effective tool. This is a huge shift. Instead of just focusing on deficits, you work to preserve the individual's personhood.
What does that look like in practice?
It means forming meaningful relationships, trying to enter the patient's world, basing care on their unique life story, not just performing tasks like bathing or feeding. This approach significantly reduces agitation because you're recognizing that distressing behavior is often communication or response to how they're experiencing their world.
That makes a lot of sense. And teaching families.
Yes, health teaching and promotion for families are core nursing duties. Table 23.7 in the book outlines key communication strategies. Keep it simple, be direct, use clear explanations, rephrase if needed, use visual cues, maintain a calm tone, make eye contact, and structuring self-care activities is vital. For dressing and bathing, let them do what they can, encourage their own clothes, use easy fasteners like elastic or Velcro, label clothing, give step-by-step instructions. Take this blouse, put in one arm, now the other arm. Always check water temperature for safety.
Okay. Nutrition. Sleep.
For nutrition, monitor intake carefully, offer easy-to-manage finger foods if utensils become difficult, weigh them weekly. And watch for that hyperorality, make sure they don't eat non-food items. For bowel and bladder, start early with scheduled toileting, label bathroom doors clearly. For sleep, keep areas well lit at night for reorientation if they wake up, maintain a calm atmosphere during the day, use sedatives very judiciously, and avoid barbiturates that can actually worsen agitation.
And creating a safe environment, that seems huge.
Absolutely critical. Table 23.9 covers this well. Gradually restrict driving. Remove throw rugs, major fall hazard. Minimize excess sensory stimulation. If the patient becomes verbally upset, listen supportively, then gently redirect. Label rooms, drawers, objects, use words and pictures. Install safety bars in bathrooms. Supervise smoking. For wandering, which is common and dangerous, consider placing the mattress on the floor for nighttime wanderers. Use medical alert bracelets. Alert neighbors and police. Maybe have them wear a bright vest in a facility. Complex locks placed high on the door can help. Encourage physical activity during the day. It can reduce nighttime restlessness. Sensor devices are also an option.
What about activities? keeping them engaged.
Yes, useful activities are important for quality of life. Things like looking through picture magazines, simple large muscle exercises like walking or maybe gentle dancing, familiar group activities like singing old songs, simple crafts, or reminiscing.
And community support.
Referral to community supports is absolutely crucial. The Alzheimer's Association is a primary resource. Their community resource finder is invaluable for locating local help, like Meals on Wheels, home health aides, respite care, adult daycare, support groups, hospice. Families also need guidance on legal and financial matters, advance directives, power of attorney. This is key patient advocacy.
Okay, let's talk about medications. What's the real picture there?
Right, pharmacological interventions. It's really important to manage expectations here. The FDA-approved medications offer only marginal, temporary cognitive improvement, maybe for 1 to 2 years, and the benefits tend to wane over time. Patients and families have to weigh the side effects against these limited benefits.
So types are there?
2 main classes. First, cholinesterase inhibitors, drugs like Dunpecyl, Aricept, rivastigmine, Exelon, galantamine, Razidine. They basically work by preventing an enzyme from breaking down acetylcholine, which is a neurotransmitter important for memory and learning. So they increase its concentration in the brain.
And side effects?
Mainly GI issues, nausea, vomiting, diarrhea. Also, sometimes insomnia, fatigue, muscle cramps, or slower heart rate, even fainting. The rivastigmine patch is helpful for people who have trouble swallowing pills.
Okay, that's one class. The other?
The other is an NMDA receptor antagonist, specifically memantine Namenda. It works differently. It regulates the activity of glutamate, another neurotransmitter. Too much glutamate can overexcite nerve cells, so memantine helps protect against that. It's approved for moderate to severe Alzheimer's and can sometimes be used along with a cholinesterase inhibitor.
And what about medications for behavioral symptoms, like agitation or depression?
Those are used, but with extreme caution. Things like antidepressants, antipsychotics, anti-anxiety meds, sometimes anticonvulsants. The rule for older adults is always start low and go slow. Use the smallest effective dose for the shortest possible time.
And there's a warning about antipsychotics.
Yes, a critical FDA black box warning. Antipsychotics, both older and newer ones, are not approved for treating dementia-related psychosis. Why? Because studies show they increase the risk of death in elderly patients with dementia, often due to cardiovascular events or infections. So their use requires very careful consideration of risks versus benefits.
Good to know. Can you briefly touch on the underlying neurobiology again, how these meds relate?
Sure. In Alzheimer's, the brain produces less acetylcholine, and what's there gets broken down quickly. Cholinesterase inhibitors try to boost the available acetylcholine. Glutamate activity is also dysregulated, which memantine targets. And structurally, you have those amyloid plaques outside neurons and neurofibrillary tangles made of tau protein inside neurons, both disrupting function and leading to cell death. Visually, if you could see the brain, you'd see atrophy. The cerebral cortex, the outer layer, literally shrivels up. The hippocampus, key for memory formation, shrinks significantly. And the ventricles, the fluid-filled spaces in the brain, get larger.
Okay. And finally, evaluation of care.
Evaluation is ongoing. Outcomes must be measurable, realistic for the patient's current capabilities, and reevaluated frequently. As the condition progresses, the goals and outcomes will need to adjust to reflect diminishing functioning. This frequent reevaluation helps reduce frustration for everyone, staff, family, even the patient sometimes. The overall goals are always to promote the highest possible level of functioning for that individual and, realistically, to delay further regression as much as possible.
Let's wrap this section by revisiting the case study of Mr. Sloan to tie it all together. Remind us of his story.
Right, Mr. Sloan. Diagnosed at 63, over 4 years, progressive memory impairment, disorientation, incontinence. He started wandering away from home frequently, maybe 4 times a week. He even fell out of bed once, thinking he was camping. This level of decline and the safety risks led his family to the very difficult decision of placing him in a care facility.
And Brian, the RN, assessed him. What did he find?
Brian noted Mr. Sloan's frustration trying to find words, that's the aphasia. He observed agnosia when Mr. Sloan pointed to his wife and asked, "Who is this woman?" Mrs. Sloan shared her feelings of guilt about the placement and mentioned his increasing difficulty with dressing himself.
So Brian's priority diagnosis was?
Risk for injury, clearly supported by the wandering history and the fall out of bed. His outcome criteria focused on supporting Mr. Sloan's highest level of function, maintaining his health, and critically, keeping him free from injury.
And what specific nursing interventions did Brian implement?
He used several targeted strategies. He minimized sensory stimulation in the environment to reduce anxiety. He used redirection when Mr. Sloan became upset, understanding his short attention span. He labeled all rooms and drawers with both words and pictures, which is great for addressing aphasia and agnosia. He encouraged physical activity during the day to potentially decrease nighttime wandering. He provided a low bed to reduce fall injury risk, and he ensured adequate bathroom lighting at night to decrease confusion and promote continence if Mr. Sloan woke up needing the bathroom.
And the rationale behind these choices.
Each intervention directly addressed a specific problem or risk identified in the assessment based on best practices for dementia care. Minimizing stimulation reduces anxiety, redirection works with attention deficits, labeling provides cues, activity channels energy, low beds and lighting enhance safety.
How was the care evaluated? Did it work?
The evaluation showed that while Mr. Sloan did continue to wander sometimes, he was largely contained to safe areas within the unit. And importantly, he hadn't fallen out of bed again since the interventions were put in place. So yes, the nursing interventions significantly increased his safety.
And Brian's self-assessment.
That part highlights the importance for us as nurses of having realistic expectations, acknowledging the emotional toll this kind of care can take, and having strong coping strategies to manage the stress and avoid burnout. It's essential. #tag outro.
Wow, that was quite a deep dive today. We've really unpacked the critical distinction between the acute, often reversible emergency that is delirium and the progressive, often irreversible nature of dementia, particularly Alzheimer's disease. And we've really seen how crucial that person-centered care approach is shifting our focus from just the deficits to truly preserving the individual's dignity and their unique personhood.
Absolutely. And remember, while neurocognitive disorders present, immense challenges for individuals and their families, your nursing interventions, the things you do every day, can profoundly impact patient safety, their comfort, their quality of life. And you also provide such vital support for their families going through it. Hopefully, this deep dive arms you with not just knowledge, but also the confidence to make a real difference in this complex and often heartbreaking area of care.
Yeah. As you continue your journey in nursing, just remember that caring for individuals with neurocognitive disorders, it isn't just about managing symptoms, is it? It's really about preserving dignity, fostering connection, and finding meaning, even amidst profound change. So maybe think, what small act of presence, what targeted intervention can you bring to a patient today to make their world maybe just a little less frightening, perhaps a little more understandable?
Well said. On behalf of the Deep Dive team, thank you for joining us. You are not just building knowledge here, you're also building empathy, and that will serve you so well as future mental health professionals.
Keep learning, keep asking questions, and keep making that difference.